Number 2 first, right? So I've introduced, oh sorry, I didn't introduce myself. So I'm Gagan, I work in Narayana Netralaya, Bangalore. I'm also a principal assessor, I'm an orbit-oculoplasty oncology surgeon. So barely do that work, so kind of deal with more emergencies than some other specialists, at least cataracts. So, the only disclaimer is I am an assessor with NABH and the views in this talk are mine, not of NABH. Can you shift the slides please? Next. So NABH, if you see, has got a fixed structure in all the standards. Like any book of NABH when you will pick, it has got 10 chapters and all those chapters have same name. So AAC is the first chapter all across. So there will be 10 chapters. First 5 chapters are so-called clinical chapter, patient-centric chapters. Last 5 are organization-centric, management-centric chapters. So I'll just pick across certain areas where emergency comes into ophthalmic standards to draw your attention there, and then based on your practice you can delve deeper and do. So in AAC1, the standard number 1 which is there, if you see, it says that organization has an emergency department with easy access. Okay, you will not find the same line in the current book, but in the description it will be there. Then you should have some documented policies and procedures how you are going to handle emergency service. Okay, then you should have a registration and discharge process, and then you should have something called a transfer process. So I'll come on to all this and just tell you what it means. So if you look at any hospital anywhere in the world, the emergency department is well marked. It's in the entry, and directly you enter any big hospital, straight away it leads to emergency. The ambulance goes there and person goes down and you have a big emergency department with 10, 12 patients. Every college, every hospital, everywhere you'll find the same. So same thing is that with emergency, the in and out should be easy. So you want emergency to be approachable. So ideally speaking, if you have 2 entrances, 3 entrances in the hospital, it could be any one of them. So there should be, if it's a big hospital, adequate signages, and access to emergency should be from the main gate. So let me portray a thing that if you have a 3-story building, first story OPD, second OPD, third OT or something. So you can't have emergency department on 3rd floor. Your entry is from 1st floor, your emergency department is somewhere on 1st floor, so that it's easily accessible. And whatever emergency room or department or whatever you are showing as per your practice should be accessible easily, means a stretcher should be able to go, wheelchair should be able to go, ambulance should be able to access. So a patient comes from ambulance on stretcher should be able to go in and should be able to go out, right? And a similar thing, before someone says the size matter, if you look at all imaging centers, they also plan a same way. You send any patient to a smallest MRI CT center, they will have a way to take that patient inside and get out on a wheelchair and a stretcher, right? So mark your emergency, it should be easy there. Patient should come, in case it doesn't matches, you should be also able to move out. Or if you have any emergency of your own, you shift to that emergency area and move out. In ophthalm, you may not have a dedicated emergency area because we don't deal with so many, but you can still earmark that emergency area and also use it for certain other purpose. But yes, in practice there should be some dedicated area. In case a patient has problem, patient should be able to lie down there. You should be able to give oxygen, give drips, or whatever is required to manage that patient. So documentation, in NABH you have to have a registration process. Patient comes, you register, you check something. So same thing in an emergency, you'll have a process. Put down on a sheet of paper that if an emergency patient is going to come, the security or first person is going to guide that patient to emergency room. In emergency room, this is a person going to attend. At bare minimum, we are going to check vitals, we are going to take history, and all those things. Just make a couple of steps, what needs to be done for an emergency patient. So that's our thing. What we do, we document that these things are required to be checked as per our requirement. And here again, I would do it in 2 ways. I would put general emergency separate and ophthalmic emergency separate, because doing them together is very difficult. So I would clearly say emergency coming, I will separate ophthalmic, general, and then go according to that. So in some case, you will have an emergency patient and you need to transfer that patient now. It's your own patient, develop some complication, you need to transfer to another hospital. Some patient has come to you, but rather than ophthalmic requires something else. So in that case, for both ways, in emergency and otherwise also, you have to have a process that how are you going to transfer a patient, which is your ambulance, which hospital you are going to transfer. Obviously, that's one of the tie-up. We'll have patient can go to another hospital. So how that is going to happen, you will have to have a transfer form, what details you are going to give along with that. So all those things you have to document, which will be required for both emergency and non-emergency patient. And unstable patient here also represents some emergency or patient requiring more than ophthalmic care in your setup. So you are operating, patient had an issue. I believe you would have got that example. Every city, you or your colleague or someone would have faced some kind of an emergency during surgery. So take that into an example and see what you did in that case verbally. That should be in paper, and we should all know those steps. The reason of putting it on paper is when emergency happens, everyone uses their brain, and brain fade can also happen. So you will be thinking something else, use something else, 3rd person. So no matter who's on duty, no matter which nurse, which staff is there, everyone speaks the same language, everyone follows the same steps. So it's really, really helpful. And then another aspect would be reassessment. So how this will matter in an emergency is that I have a patient, I'm on call, and I've admitted a patient. Okay, patient has a small lid laceration, came to plasty as an emergency, I think. But the main problem is there is a vitreous hemorrhage, there is retinal problem, there is some tear, something else, retina needs to handle. So I need to hand over the patient from plasty to retina. Okay. Or if the patient is under me, like let's say I've admitted some cellulitis patient or something, then I need to reassess patient. So we always say, morning round, evening round. So that morning rounds, evening round is nothing but reassessment of patient. So when we say morning round, evening round, it assumes that we are reevaluating patient at every 10 to 12 hours. So same for emergency patient, you reassess a patient if patient has come to emergency department is there, and now you plan to do corneal laceration. Patient is sitting there. So someone has to check on that. So formulate a policy on that. You may also need to have some lab services if it's a very big hospital. So basic lab services may be required at night in case you are getting a patient and you are also planning to operate on those emergency patient. Right. And this one is there. I'll come next to this initial assessment for emergency patient. So what will happen is, I discussed earlier also, every patient you need to have some initial assessment. Emergency patient is going to take history, you are going to check for BP, vitals, what kind of injury it is, and then you are going to triage and all which will come further. So that process is your initial assessment, and you have to formulate how it's going to do. And normally it's good to have a standardized process to an extent so that it helps, and other things follow on that. And nursing assessment also is a part of this one, initial assessment. In some cases, if you are admitting emergency patient, they will also require nursing assessment, which again has to be done by the nursing staff. This is only for overnight stays, like daycare it will not be required. So other thing is, who's going to perform initial assessment? So this is a question to you. If a patient is coming to hospital, or if you go to any hospital, who is the person who should be attending to an emergency patient? On duty? Doctor. So let me put doctor. So during assessment, many a places, if it's, some practice, the doctors are not attending. That's a fact. So there'll be, sometimes optoms attending, sometimes there's a nurse who's first or something. But anyways, an emergency room can be manned by a nurse or a doctor because they are trained for that legally. So even a nurse can be the first responder and the doctor can be the second responder. The first responder for emergency usually will be a doctor or a trained nurse. Okay, optoms unfortunately are not clinically trained and our technical staff is not trained. That becomes a problem somewhere. Okay, and then you have to have a time frame that how fast we are going to attend to a patient, 5 minutes, 10 minutes, and you have to monitor that. How much time over? You just had a brief, okay. So along with initial assessment, when you are having that emergency room which I showed you, you will also have to look at documentation, need to have an emergency register separate. So emergency register can be separate from your main, maintain that. MLC if required, even if you haven't had MLC in last 10 years, you never know when you get. So the process of registering an MLC should be known to you, and things which are required to do so should be available with you. And monitor all these things, whether they are actually happening or not. Then again, we have discussed qualified individual part, so we can move next. Now again, we talked about patient being transferred from one department to other, one shift to another. Someone told we'll have a duty doctor, so duty will end sometime. So whenever that happens, the patient has to pass on to the next team. So that is what we mean by sharing the information and handing over the patient to next department or next team about what we have done, what we are finding, and what is expected and what is the issue. So that thing has to be done. And so other thing there would be that as per Act, Clinical Action Act and various judgments, we need to still have a process for setting up an emergency department. We cannot refuse a first aid or the first examination to any other emergency. So we can't say it's only pure ophthalmic. So bare minimum, those basic things can be there. Once we attend to a patient, we can always transfer the patient saying that it is not in our scope or we are not equipped to do that. But that initial assessment or initial thing has to be done. That's what it is. How you handle is up to us. So that will be your first thing that, okay, you attend, and then the transfer thing kicks in if that's what the scope is. So you should also know what are MLCs and when to do an MLC. It doesn't mean that if patient says, I don't want MLC, and doctor says, I don't want MLC, it can't be MLC. You can treat a patient, everything done. After 1 or 2 years, you will get a notice from court also telling to give all documents, or otherwise it can be earlier also. Okay. And other thing, triage. So once you get patient, we discussed ophthalmic emergency, non-ophthalmic emergency. Next step is triage. So typically 3, what requires the immediate attention, urgent or something not. Like, so let me take a very simple example. Acute conjunctivitis coming at night, seen by the duty doctor. What do we do? Very simple. Patient goes off and you advise follow-up, probably 5 days, 7 days, whatever is your protocol. But whereas if that patient is something of an infection thing, you will probably see early. If that patient requires some surgery, you will be probably planning for an emergency surgery. So that is a kind of a triage based on that. So you'll have categories mentioned that in emergency, these are the category: chemical burn or trauma or laceration, perforations. These are urgent, corneal, these are semi-urgent, or something like that. So categorize into your triage, and accordingly you will manage. And that can be documented and put up in the emergency room for everyone to know. So ambulance again is required. Most of us will have an MOU with an ambulance provider. We don't have our ambulances, but wherever an ambulance is there, the criteria remains same. So if you have outsourced, we need to have certain ambulance things. So if you have a good provider, all these things will be there, where ambulance checks and things are maintained. And quickly, this is another part of emergency. If you have a patient where patients are even in daycare and you are having 50, 100 patients in hospital, you will need to give them some kind of an access system that they can contact you in case of emergency. Ophthalmic manpower, that way, for 50 patients, there will be only 2-3 people manning the ward. So we can have certain system where patient can actually tell you or have a call points or panic points when they can inform if they are having any problem. And other important thing is CPR, code blue, cardiopulmonary resuscitation. For NABH, that is mandatory. So all your staff has to be trained on that. You have to train up for that, and then basically you'll have to form a code blue team. We call it code blue. It's a universal term. And in that code blue team, you'll have your documentation. You will have to have mock drills, and that is to be done on a periodic basis. And for doing this, you will also have to maintain your emergency crash cart or emergency trolley and the equipment which is required for CPR, at least basic life support. Okay. And if you are doing any procedures on this emergency patient, you also need to have a proper consent. The concept of patient came in emergency and patient is consented for whatever we need to do does not apply. So no matter what, even if it's an emergency patient, the consent needs to be taken, and it has to be an informed, proper consent if you really don't want to have problems, at least in bigger cities, where everything is going for a problem. A normal routine patient is going to having some issue. Okay. So medicine, again, there is an MOM chapter in NABH which deals with the management of medication. So same thing we discussed, we should have a crash cart. Same thing, we have to define our emergency drug list. We have to define what quantity we are going to maintain, how it is going to be maintained, keep a check on that, and how we are going to store. So the biggest thing is if you stored, like for us it was happening, that emergency room is accessible. Whenever someone needs something, the injection is picked from emergency room, then they will replace it from ward or something. So those things doesn't matter. If they don't replace it when you actually want, it's not there. So make sure that everyone knows that thing and we keep a check on that. It's not that emergency room, when we actually need things, nothing is working. So please keep a check on that, not only for external patients coming in, for our own patients which we are treating. And then again, for these patients also, you will have certain standard where we will see that how well you are informing families of these patients, what information we are giving, costing, what intervention has to be done. So after a while, once you have attended an emergency patient, virtually we have to treat them like a normal patient and have all those consents and other things being done for them. So if you are having a separate emergency, so this part will be done in emergency area, because then that ward or that room is separate. So that's why this will be separate standard. If it's a common hospital, common ward, then everything becomes common after a while. So this will be the last. In HIC section, if you go, which is hospital infection control, it defines your hospital into different areas. So under HIC, your emergency will become a single area. So all the HIC practices for your emergency area have to be put in as a separate practice. So your OT will become separate area, ward will become separate. So simply put, your infection control practices in OT are not same as ward, right? Ward is basic clinic, OT is much else. So same thing you'll have to plan how it is going to be done, and that is another thing which you will have to plan for that. Thank you. That's a brief overview.